So with that, we're now starting recording. The first interesting piece of news to share with you is we've had an apology from Dr. Tigist Zerihun, whom you know is one of our to-be specialist registrars. Her reason for apology is today is New Year in Ethiopia. So isn't that interesting? Just for us to remain culturally sensitive about the world. So in Ethiopia, according to their Coptic calendar, this is the start of a new year. So Happy New Year to Tigist, who's not joining us today. But number two today, Ros Adlard, who's one of our registrars, will talk to us about Disruptive Mood Dysregulation Disorder. And it's a literature review that Ros has obviously chosen to do. So Ros, I think this is an interesting conversation, and I will hand it over to you to say how you want people to join, but I'm sure you would like some discussion at the end about the constructs and the concepts of disruptive mood dysregulation disorder as well. So with that, I'm going to hand over to you.
Right. Thank you, Prof. Yes, so thanks everyone for being here. I decided to take this topic because essentially I realized that this wasn't a topic I knew very much about, and I thought it would actually be good for my own learning just to get a good review article on some issues that I didn't know much about for these presentations. So this is my first one. So when I trained, actually disruptive mood dysregulation disorder wasn't even in the DSM yet. As I'm sure many of you know, it's only come in the DSM in 2013. So essentially, this is an article that I've chosen, which is actually published last year by an Italian group of scientists, Bruno et al., and was published in Psychiatry Research. As I said, it was published last year. So, okay, so as I've said, it's a new diagnostic entity that's been brought in the DSM-5. It's essentially characterized, its main features are non-episodic irritability, in other words, chronic irritability, as well as severe temper outbursts. Those are the main features. I'll show you the DSM-5 criteria in a minute. These children are prone to disproportionate anger. So the temper outbursts are out of proportion with the trigger for the temper outburst or for the provocation. And they might be either behaviorally or verbally manifest. So they say in the introduction that this has been a rather disputed diagnosis when it first came out, largely due to the lack of valid empirical studies, as well as the lack of treatment guidelines for the disorder. So they diagnosed, or they had the disorder, but as I understand at the time, there wasn't really any clear treatment guidelines where you can diagnose it, but how do you treat it? They do make the point that it was diagnosed due to concern around the increasingly diagnosed or increasing diagnosis of bipolar mood disorder in young people. And they say that it was similar to what SMDD, which is severe mood dysregulation disorder. So severe mood dysregulation disorder was introduced in the DSM-4 they said to forecast the development of the bipolar spectrum disorders in youth with irritability. They're quite similar. So SMDD and DMDD are really very similar in their criteria. However, they removed, SMDD did include a hyperarousal criteria, which they said was insomnia, distractibility, agitation, racing thoughts or flight of ideas, pressured speech, and intrusiveness. So that hyperarousal criteria that was part of the SMDD diagnosis is now no longer, it's not included in the DMD diagnosis. So these are the DSM-5 criteria. So severe recurrent temper outbursts, as I said, they're inconsistent with the developmental level. So they need to occur 3 or more times a week. The mood, and what's important is that the mood in between the temper outbursts is persistently irritable or angry for most of the day, nearly every day, and is observed by others. Duration must be, you must have a 12 months or more duration without more than 3 months of symptom-free interval. Symptoms must be present in at least 2 settings. Age at onset before 10, and you can't make the diagnosis before 6 or after 18. You need to not have ever met the full symptom criteria for a manic or hypomanic episode for longer than 1 day. Behaviors are not exclusively during a major depressive episode and are not better explained by other disorders. And just to note that this diagnosis cannot exist with bipolar disorder, intermittent explosive disorder, and oppositional defiant disorder. So you cannot have those two diagnoses together. And then they can't be due to substances, medical, or neurological conditions. So the methods of this paper, it sort of goes into more detail in the paper. You can have a look at that, but essentially they wanted to collect and analyze all the recent literature on the DMD diagnosis and its main hallmarks. They looked at they did a database search of PubMed, Scopus search paper, Web of Science, and Science Direct. And they give the search terms in the paper. I won't go through it all. And they had no limits or exclusion criteria. They essentially took every single paper that came up in the original study case report, case series, meta-analysis, and systematic review. And they also looked at references of those papers. This hasn't, I don't know if you can all see this very well. It's a bit blurred. My screenshot skills need to be improved, but this is essentially just the flow of the, so essentially of the papers that they identified, and eventually they included 70, I think, papers, if you can see that. Yeah. So in terms of the clinical features, okay, so irritability is the core feature. It's noted to be, as I've already said, chronic and persistent, occurs in different settings most of the day, every day. And the type of outbursts being out of proportion to triggers. There, okay, so, sorry. So there is an element of inattention and distractibility as well that's been noted, as well as psychosocial impairment. So this was a study from North Carolina, where they said that the children with DMD exhibited more psychosocial impairment than other children. And this is particularly evident in relationships with parents and with siblings. The children also came from, sorry, I'm just having a look at my notes. There was a higher risk of later psychopathology in the children with this diagnosis, including a higher risk of depression in adulthood and anxiety, as well as of risky and illegal behavior. So they noted that chronic irritability was not predictive for bipolar disorder, as episodic irritability was thought to be, but rather it was a marker for depression and anxiety in adulthood. Episodic irritability is linked to bipolar diagnoses in adulthood. Youth with DMDD were more likely to have impaired activities of daily living, learning difficulties, self-harm behavior, and suicidal ideation. Compared to their peers with another psychiatric but non-DMDD diagnosis. The children, okay, sorry. So they were more likely to have general health issues compared to healthy controls, so such as worse health outcomes. They also had general health issues, such as high rates of STDs, smoking, illegal or risky behaviors, and so on, physical fighting and illegal activities. They were more likely to come from single-parent families or disadvantaged families. And they were more likely to have other psychiatric comorbidities than the controls. In terms of the prevalence and epidemiology, just to note that most of the studies done are retrospective, and a lot of them refer to the SMDD diagnosis rather than DMDD, partly because DMDD is a more recent diagnosis. there's a study, the Great Smoky Mountain study, which is done in the US, in North Carolina, I think, showed a prevalence of 0.8 to 3.3%, with the prevalence decreasing with age. So it was more prevalent in younger children, but less in the older children, adolescents. And they also noted that the strict application of the symptom duration and frequency criteria has restricted the number of DMDD cases. So in terms of the pathophysiology, so there was a study done using fMRI, event-related potentials, and magnetoencephalography, which compared episodic and non-episodic irritability. So the SMDD type irritability to children with bipolar disorder, episodic irritability. And this showed that there were different neural circuits responsible for the attention deficits. They found that in the SMDD children, there was there were problems with the bottom-up attention, versus in bipolar disorder, there was the deficiencies were more in the top-down executive attention. SMDD children also showed hyperarousal, elicited by frustrating stimuli. So this was in conditions where the children were being frustrated, they showed more of a hyperarousal type picture. Okay, so in terms of the, okay, then there was a study done showing dysfunction in emotional processing, which was implicated in aggressive reactions of these children. And it seemed that they had difficulty in identifying facial expressions, especially more negative emotions. So there were problems there, and they say this is possibly leading to the experience exaggerated fear in the presence of neutral faces. There was a study done of frustration tolerance in children with SMDD that showed that they had increased frustration and difficulties in shifting spatial attention compared to controls. And they had decreased activation in regions involved in emotions, attention, and reward mechanisms during these times. In a facial affect recognition task, showed abnormal amygdala activation in the DMDD subjects, which was related to irritability and intensity. And DMDD patients also showed excessive amygdala activation for all facial emotions compared to bipolar subjects who only had the excessive amygdala activation for fearful faces, for fearful expressions. There were a MEG study which was done, showed different neural pathways to negative affects. The SMDD youth had greater activation of the medial frontal gyrus and the anterior cingulate cortex, whereas patients with bipolar, sorry, I keep on saying borderline, bipolar disorder had reduced insular activation and enhanced superior frontal gyrus activation. Okay, in terms of risk factors, essentially there are limited studies looking at early risk factors, but there are some that are known. Environmental and genetic factors are thought to play quite a role, although it is thought that genetic influence is possibly more important in younger children than environmental factors, which I found interesting. There were also gender differences in that it seemed that girls might be more prone to genetic influences than are boys. Okay, parental psychopathology is associated with an increased risk in children. Notably, mothers with peripartum depression seem to have a higher risk of having a child affected, as well as paternal depression and substance use were also associated with higher risk. Yeah, so just to say, paternal depression and substance use were factors for worse symptom patterns of irritability, and maternal depression children had higher rates of diagnosis, with also with a greater severity of irritability. In terms of environmental factors, early trauma is thought to play quite a large role, specifically psychological trauma and abuse. Other risk factors identified were one or both parents not living with the patient, or where one or both parents had not completed college. And then grief, divorce, and malnutrition and vitamin deficiencies, specifically iron, B12, and folate deficiencies, were also identified as risk factors. Okay, so in terms of comorbidity, there are extremely high rates of comorbidity of this condition. The main comorbidity is around ODD, conduct disorder, and ADHD. However, bipolar disorder is actually less likely to be comorbid with it. So in terms of ODD, this is the main condition that is found to be comorbid, and the rates are up to 96%, which seems really shockingly high. There is a lot of diagnostic overlap between ODD and DMDD. So just to quickly refresh your memory, I'm sure you all know about ODD, but so the ODD criteria include a pattern of angry, irritable mood, argumentative or defiant behaviors, and revengefulness for at least 6 months. And then it's got to be accompanied by 4 features in terms which include often losing temper, often touchy or easily annoyed, often angry or resentful, often arguing with adults or authority figures, often actively defying or refusing to comply with requests and rules, deliberately annoying others, and often blaming others for mistakes or misbehavior. So there really is a lot of diagnostic overlap between these two conditions. However, the DSM, as per the DSM, you cannot diagnose ODD if the patient meets criteria for DMDD. It's also just worth noting that
this is Petrus. Sorry to butt in. It is typically the other way around. So if somebody meets criteria for ODD, we wouldn't diagnose DMDD. So I don't know if it goes in the other direction as well. We can maybe have that discussion when we get to the end. Okay.
Well, thanks, Prof. Sorry, and from my impression of reading the DSM, I thought that's what it was saying, but maybe I misunderstood. So just to mention, the DSM does say that although a large proportion, so as I say here, 96% of patients with DMDD have got ODD, the opposite isn't true. So it's only about 15% of patients with ODD actually have DMDD, which I found interesting. Okay, then ADHD, rates of comorbidity up to 81%, and conduct disorder around 13%. It's important to note that the cardinal symptoms of DMDD, being irritability and temper outbursts, are quite common in various disorders, including ASD and ADHD. And they go into a bit of a discussion in the paper about this. So emotional dysregulation in youth with ASD is really quite common. I think they say 1/3 of children with ASD have maladaptive emotional problems. Although the chronic irritability and angry mood are distinct from typical ASD symptoms in that they are better or more responsive to treatment with pharmacology, but they are related to psychosocial impairment, harmful consequences, and emotional distress. And also they're associated with more severe social impairment in these children. So they say it's not clear whether the mood dysregulation, the mood dysregulation is essentially a comorbid or part of the same condition, whether they're comorbid or epiphenomena. And part of the difficulty of this is that there's more evidence for DMDD being associated with parental depression than with parental bipolar disorder. Episodic irritability in youth is usually associated with GAD and mania later on in later adolescence and adulthood. So the episodic irritability is more associated with GAD and with bipolar disorder than the chronic irritability of DMDD, which tends to be more associated with depression and anxiety. Okay, so in terms of the treatment options, since there are no clear, as they say, there's no clear sort of guidelines specifically for treatment of this disorder, but the treatment essentially needs to target the core symptoms of DMDD. A lot of studies done here, again, refer to SMDD. So there is an issue with a lack of actual studies around DMDD diagnosis. Prior to DSM-5, they said that there was a concern about using antidepressants and stimulants in these children with this chronic irritability because there was a concern around switching to mania or worsening their irritability. However, evidence of the relationship between DMDD, unipolar depression, and anxiety disorders have now sort of paved the way to using more psychostimulants and antidepressant use in these children because it seems like these are more, you know, on a spectrum, I suppose. So that's my understanding of what they were saying. So there is documented efficacy in ADHD on aggressive behavior for these medications. Atypical antipsychotics such as risperidone and aripiprazole are also efficacious in treating aggression and irritability, and they are used in DMDD and SMDD due to their beneficial effect on children with ASD. Methylphenidate, with or without risperidone, is also shown to decrease aggression in ADHD. And then the alpha-2 agonists are shown to reduce aggression in ADHD as well. There's evidence also for lithium and for anticonvulsants, showing a moderate reduction in aggression in children, as well as one case report on naltrexone. They say that this improved aggressive outbursts and functioning in an adolescent male with DMDD. I'm not sure if there's any other evidence for that. So one case report maybe isn't very much, but I thought I would mention it. Since it was in the paper, I thought it might be interesting. The theory is that the endogenous opiates, either directly or by modifying dopaminergic pathways, are involved in repetitive self-injurious and addictive behaviors. Okay, so in terms of psychotherapeutic or non-pharmacological treatments. Psychotherapeutic treatments are very important, like such as behavior therapy and parent training interventions. These are a cornerstone of treatment and should always be implemented in these children due to the impairment in social functioning and the emotional dysregulation. There has been a randomized controlled trial showing a response to DBT for children, for pre-adolescent children, which had a response rate of 90.4% in patients with severe emotional and behavioral disorders. They noted that this was with a parent training component to it. They say that parental active participation was extremely important to the outcome, and also that the improvement in functioning that was achieved by the DBT also helped with treatment compliance. So that may have been also a helpful factor in the study. So I thought that was interesting. And then my last bit for me, looking at conclusions and future perspectives. So as has already been sort of mentioned, the DMDD diagnosis did receive criticism after the DSM-5 publication. There were concerns around increased pharmacological treatment for children. There was concerns that there was a lower threshold for psychiatric diagnosis. After all, anger and temper tantrums are really common in childhood. And, you know, there's concern, I think, that all these children are now going to be labeled and pathologized and treated for something that was, you know, essentially possibly a normal childhood phenomenon. The ICD-11, which I understand isn't formally out yet, but has been published for comment and so on, proposes that DMDD be a diagnostic specifier of ODD rather than its own separate diagnosis. No peer-reviewed research was conducted for DMDD prior to its inclusion in DSM-5, and further studies are therefore needed for validation of the diagnosis as well as for treatment. In terms of treatment, medications usually, up to now, it's been usually medications that have been used in adult bipolar disorder, which have been predominantly used in these children. And these medications have got side effects and require monitoring. There are we need further trials essentially to determine more information around the safety and efficacy of medications in youth with DMDD. And I think that's all from me. Can I stop screen sharing now? Right. So thanks everyone. I mean, it's interesting giving a talk like this as a registrar, because I'm giving, you know, normally talks are given by people who are experts in their field, and I'm very much not an expert in this field. So I would really like to hand over now for discussion. I mean, just one or two things that occurred to me looking at all this information and so on was, you know, I had a child last week that I saw who I was trying to understand whether this child was chronically irritable or more, episodically irritable. You know, he definitely has a sort of an ODD and irritability and temper tantrums, but the mother, I think, especially if you have a slightly disengaged parent who's maybe not terribly attentive, the mother, you know, or caregiver can't necessarily give that history, or that was my experience, and the child couldn't really tell me. So yeah, that was just one thing that occurred to me. Actually, this it may not always be too easy. It sounds fairly sort of obvious to say, oh, well, it's chronic or episodic, but that distinction clinically isn't always too easy. So that's one thing that's occurred to me in just thinking about this and making the diagnosis. And the fact that you can't make the diagnosis together with ODD, although there is a huge overlap between them, it's interesting. You know, part of me was thinking, wasn't this just the same disorder? Anyway, so those are just some thoughts of mine that maybe people would like to share their greater experience and expertise about.
Excellent. Thank you, Ros. This is the point. I'm going to stop the recording, and then I'm going to invite everyone on the call to join in a discussion, because I think it's a diagnostic category that certainly requires discussion rather than to swallow it lock, stock, and smoking barrel. So let me stop the recording, and I'll ask the rest of you to put your screens on.